At this time, I would like to introduce you to our speakers, John Bain and Lori Daigle. John Bain, Stroudwater Revenue Cycle Solutions President, has over 25 years of experience in healthcare financial management and consulting. His focus has been on Chargemaster auditing, revenue cycle initiatives, and hospital and physician practice management. He has extensive experience with solo practitioners, large group practices, small community hospitals, and large academic institutions. John has led initiatives to increase physician and departmental productivity, to implement physician-specific hospital-wide revenue cycle protocols, and to develop Chargemaster maintenance policies and procedures. He has successfully grown gross revenue and net reimbursement through combining operational improvements, Chargemaster effectiveness, and efficient business office protocols. Lori Daigle is a certified professional coder with over 20 years of experience in medical insurance, claim processing, medical billing software training, and healthcare financial management. She focuses on coding and business office auditing and training initiatives, revenue cycle improvement, and hospital and physician practice management, and research and development of periodic updates to support coding, billing, and other departments in compliance with regulations and requirements. On that note, I'd like to welcome everyone and thank our speakers for being here. And John, if you're there, I'll hand it over to you.
Well, thank you, Andy, for the introduction, and welcome, everybody. Very appreciative of you taking some time out of your busy day and realizing that you're trying to take maybe some advantage of gaining some insights that might help us in our revenue cycle crisis mode that we seem to all be in right now. So Lori and I are really appreciative of you, spending a couple of minutes with us. And one of the things that we wanted to do today is build off of the presentation we did about 2 weeks ago when it kind of got into the Chargemaster process and how we could really start incorporating better practices into our revenue cycle. Because I think one of the things that we're in right now is, in this unpredictable time, we don't need our revenue cycles just to get by and to do what they've always done. We need revenue cycles to thrive. They need to perform. We need to actually get them to be better than they ever have before. And really the only way that we can do that is by taking a step back, focusing on the fundamentals, and making sure that the foundational elements of our revenue cycle are not just good, they're great. And we've got controls in place. So when we start talking about things today, we're going to try to do things through that mindset. And I think one of the things that's great is, as we're trying to figure out in crisis mode, the hardest part is for us, especially on the finance and the revenue cycle side, to feel as though we're in control, that we're doing something to contribute. We can see all of our clinicians out there doing just wonderful work and trying to help our communities and keep things, as good as they can possibly be for our hospital and our community. We just need to feel on the revenue cycle side that we can perform, we can contribute, and we can do the things necessary that might be able to help leverage and really help our clinicians do even better. So that's the mindset that we want to do as we start walking through a lot of these things. And, so what are we trying to do during the presentation today? So it's important for the Chargemaster and your revenue cycle, it has to be an administrative priority. Unlike any period of time that we've ever had, this is where revenue cycle has to be an administrative priority. We need to make sure that our process is based on communication and expectation. Two words that a lot of times that we don't use in our revenue cycle process because a lot of revenue cycles aren't based on good communication. That is, in a way, a lot of times their Achilles heel. We need to fix that. Likewise, we need to understand that we have to have expectations for people to perform. And a lot of that time means that we just have to have a better perception of what people do. Likewise, even regardless of the crisis that's going on, we've got all of these other things that are happening, from a pricing transparency standpoint, from a patient expectation standpoint. We're going to review some of those things. How do you put yourself into a better light and make it so that your revenue cycle and your pricing and your Chargemaster can be a competitive advantage? How can you use quality as an opportunity? Maybe you've never really used the word quality in your revenue cycle. We use it obviously in our clinical components, but from a revenue cycle standpoint, maybe that's a new concept for us. We need to figure that out. How do we use all of these pieces to really go through and build a better bridge for us so that we can make this and get into a competitive advantage? And we're going to bring in some things that, we're talking with hospitals across the country and where things stand and try to reflect on how we can install best practices. So when we start talking about your revenue cycle, one thing I think everyone can agree on is that the revenue cycle culture in your facility, it is a strong thing. I mean, it likes things the way it's been. It likes things to allow you to say that we've always done things this way. And a lot of times our culture is not based on being a change agent, right? So we have to understand that the culture, it impacts every component of our revenue cycle. And when we look at issues throughout our revenue cycle, like we talked a little bit about last time, all of the issues, the concerns, the excuses within our revenue cycle, they repeat, okay? And when we really look at it, and we kind of lump and silo hospital revenue cycles across the nation, in our experience, they fall into 4 categories. And we went into this a lot in the previous webinar, but we've got those hospitals that are sort of the false start. Well, so from a revenue cycle standpoint and a Chargemaster, they try, they get going, and they're going to change their pricing methodology. They're going to implement new revenue capture methodology, and something else comes up. So then they have to start all over again. Or we have the treadmill hospitals where we try to do it, and what we end up having is we have a Chargemaster improvement conversation that has been the same conversation that's lasted 4 years. Or we've got the excuse maker hospitals that find every other way to allow the culture to win. It's the way we've always done it. It's not my job. I don't know whose responsibility that is. All I know, it's not mine, right? And then we've got the doers. We've got those hospitals that have looked at it through the lens of, everything I do makes an impact not on my hospital, but my patients. And we're not going to accept excuses. And what we're going to do is we're going to take daily action to make sure that we represent ourselves the way that we want it to, and we're intentional on our revenue cycle. So a huge part of that is to really understand and focus in on expectations. Okay? So the success of the revenue cycle is directly proportional to the level of administrative expectation. So a lot of times we go through and we'll talk with CFOs and CEOs, and we'll ask them, say, guys, what do you expect from your revenue cycle? And a lot of times they pause. They're not sure how to answer that. And we have to start prompting, saying, okay, so, when you look at your revenue cycle, and this kind of goes back to what we talked about in the first presentation as well, they don't really have a good definition of what their revenue cycle is. So we start prompting them about things, about how you want to set, maybe it's cash flow, maybe it's customer service, maybe it's, your low denial rates. But, when we come back to it, the best practice revenue cycle operations are based really on clear, concise administrative guidelines and expectations. If your revenue cycle is going to meet the unprecedented needs that the hospital has right now, you need to be sure that at all expectations that are labeled, that we're communicating those, that we make sure that everybody throughout your facility from the business and revenue cycle side is on the same page. This is really where we also make the customer service, quality, people, and education a priority. If you can imagine, the amount of information that's coming to you guys on a daily basis is unprecedented. You're getting emails from everybody with all well-intended pieces of information, but how do you go through and make sure what's appropriate for your facility? We need to make sure that we've got the communication modules in place to vet some of this stuff and then take advantage of those things that come across that we should be taking advantage of. Really, hospitals struggle where there's ambiguity, lack of direction, and lack of clarity. And right now, that is an area where we're in, from a crisis mode standpoint, we're not sure what we're supposed to do. We're on information overload. And a lot of hospitals we're talking with, that information overload is leading them to paralysis. They're not taking steps that they need to do. So we need to, in order for us really to be effective, okay, administration has to understand, support, and empower their revenue cycle. So we want to really set an expectation of excellence. If we're not going to do that in the past, we need to do that now. We need to make sure that we do everything right. Okay? So in order for us really to move forward, you know, we have to understand we've got teams that are meeting and they're trying to do the best they can to give us the results. Everyone has to understand, you know, why they're meeting. Okay, what are we expecting out of our meetings? A lot of times we've got revenue cycle meetings that have been taking place, but they're not productive because they don't know why they're meeting. There's no expectation on what's supposed to come out. You know, we deal with some problems, but we never focus on the outcomes. You know, so this is where administration really can focus in and say, okay, so let's if we're going to meet, we got to focus in on customer service and quality, and we've got to empower my people to do what they need to do. We need to have accountability and ownership, and all of these things combined to allow us to have financial viability. And those components there, I don't care where we talk, it can be Chargemaster, it can be pricing, it can be revenue capture, business office operations, all of those components there go towards best practices. We clearly set our expectations, and a lot of times CFO and CEO can't do this on their own. This is where we have to pull people together, understand what everybody does, and then collectively set a period of expectation that we can go through and we can raise the bar of our revenue cycle performance. You know, so we want to measure these items. Once we decide on these things, whatever we focus on, we're going to get done, right? So we got to measure it. And then whenever we go through, the most important piece, and a lot of the difficulty really arises, is when we try to set an expectation, you know, moving forward that needs to incorporate quality. And one of the things I wanted to do is I want to bring Lori into the conversation for a moment here to just chat. So I know that we're talking with hospitals across the country about setting up revenue cycle steering committees, and we're trying to really set that level of expectation. Do you have any you know, suggestions on really when they start meeting, how does the CEO and CFO set some of those expectations, and how do they incorporate those into their business practices, Lori?
Well, I think first of all, it's very important to have minutes to every meeting and to make sure that as a result of the minute, activities are assigned to people, that each person has a task they're required to complete in order to affect whatever improvements being worked on. That has not only a task assigned, but it has an expectation of a completion date when they will be bringing their project back to the committee. And if you don't have all of that, you can't hold people accountable because they really don't know what you're expecting of them.
Yeah, and I think, you know, from a Chargemaster standpoint, that's a really good, you know, concept, because we're not talking about allowing people, we need new codes because, say, we're doing telehealth and telemedicine and new lab codes. This isn't stuff that we can allow, you know, a 30-day respite on. We need action today. So we've really got to set that expectation for people to go out, get the information, and bring it back really quickly, and have a way to imply that we're going to get it right as well. And this kind of goes towards quality. You know, so when we look at it from a quality standpoint, clinically, all of your facilities undoubtedly have a zero defect mentality. Nothing can go wrong. From a clinical perspective, any quality issues that arise have negative implications on our patients. So clearly, we want to make sure we do everything to eliminate that. We need to have the same type of concept when it comes to our revenue cycle. We've got to have that zero defect mentality. It's got to be an obsession. It's got to be something that we look at things and we say, we're going to demand quality throughout the process, but understand that it's going to take time, direction, and constant action. Success when it comes to identifying quality is never an accident. It is always intentional. But at the same time, as we start moving forward, the hospitals that make a commitment to quality in their revenue cycle, it is a competitive weapon. I mean, and when you look at it, it's one of these things that we take for granted on the clinical side, that it impacts every single area of patient involvement. Likewise, on the revenue cycle side, quality, it impacts every operational area and employee. And we need to make sure that we take this seriously. So how do we do this, right? So, you know, every facility really has to design a process that demands a relentless pursuit of perfection. So when we look at it from a Chargemaster standpoint, what does that mean? That means that someone's always looking, revising, understanding the components, so that when we say, does this department own their Chargemaster, the answer is yes. Why? Because I'm informed. We know all of the components that are there. We've got high standards, right? We don't use the Chargemaster as maybe a purely statistical thing, or we don't have things that we just enter descriptions willy-nilly. We have a very consistent methodology, you know, and when we put things in, there's a customer focus. We put descriptions into our Chargemaster so that patients can understand. And if patients can understand, so can business office, so can payer, right? And really what we talk about is often, you know, the best revenue cycle people in your facility, we always kid with them that they're kind of like the skunk at the garden party. You know, people look at them and say, oh God, here she is again. But here's the thing, these people, they've got an unrelenting and unapologetic attention to detail. It's not just okay to kind of possibly get it right. They focus in on saying, you know what, we're going to do everything we can to make sure that it's perfect. And quite frankly, sometimes that takes a couple of minutes. We can't be reactive. We've got to be opportunistic, and we've got to be proactive in our policies. And these people, they're also ridiculously consistent. They apply the same process time and time again. And what they really do as well is they focus out on outcomes and results. A lot of times when we look at problems within the revenue cycle, we don't do that. We fight fires. We never fix the initial part, and we don't necessarily see what's happening at the outside. In order for us to have a revenue cycle, we've got to incorporate all of those pieces. And really, it does come down to doing things right the first time, every time. Okay? So when we look at it, the pursuit of quality has the goal of exceeding customer expectations. And here's the thing about customer expectations. From a clinical standpoint, when they show up, regardless of how they feel or what their malady is or anything, they expect to leave the hospital better than they arrived. So that's a really high expectation. Likewise, you know, from a revenue cycle standpoint, man, they've never been educated like this before. They know more about oftentimes their coverages and what they should pay for and what they shouldn't pay for than anyone in your facility. We need to be sure that the revenue cycle is aimed at being able to meet that head on and exceed those expectations. When we look at it, and the attention to quality really incorporates in your facility, we see lower costs. We see increased margins, and we see the that internal accountability and ownership just blossom. It's really a beautiful thing. So when we sit down and this isn't like two people control the entire revenue cycle. It is a team. There's communication throughout. People are on the same page. And really, it allows us to focus in on all of the aspects of revenue cycle operations from start to finish. Not just maybe one or two steps. We incorporate everything. And by doing that, boy, the customer feels that. It is a really important aspect, you know, to our operation. So when we go into hospitals, for hospitals that from a Chargemaster or revenue cycle standpoint, when they really focus in on quality and they are really best practice and high level, what do we see? They're organized. They've got just a commitment and a diligence to detail. They're prepared. They know they've got things set up so that they get notifications of changes, and they've got a process to implement those changes and make sure that people throughout the organization know that something changed. They're consistent. People know what they're going to do. They're accountable for what they're doing, and they own their process, which is hugely important. This is not the place where you have, it's not my job. This is the way we've always done things. These are not excuse maker hospitals. These are doers. Then when we get to lower quality operations, what do we see? You know, so we see, you know, we walk through and you see the workstations. It looks like, a pad of paper has just exploded all over the place. There's just claims. Everything is all over. They show up for meetings and they're wasted. We don't get anywhere. We've got an inability to act. I mean, right now we've got a lot of people trying to figure out how to handle telemedicine and telehealth. We've got hospitals there that, have never really focused on process, and they're having the hardest time trying to figure out how to incorporate and put best practices in around telehealth and telemedicine. They have no communication. They've got chargemasters that are too big. They don't represent today. And they've got this us versus them mentality. Now, one of the things that we've got is if you look at all of those components right now, in the crisis management that we've got now, we can't afford any of these items to be incorporated into our revenue cycle. We've got to take a stand and make sure that we're focusing in on making sure that quality is job number one. Okay? Ultimately, there's no one way or all-solving process to address quality concerns. It's not a cookie-cutter thing. Everybody's got their own culture. We've got to figure out how to take advantage of the people that you've got and incorporate a process that allows quality to flourish. We've got to design those mechanisms to measure revenue cycle quality. First and foremost, you guys have to define what revenue cycle is in your facility and make sure that everyone is singing from the same sheet music when it comes to that. We've got to make sure that we may have different areas of importance. You've got to identify and find your areas of prioritization moving forward, especially now. Okay, we need to figure out whether we're focusing in on denials. You guys can't afford not to get paid for everything right now. We got to make sure that your clean claim rate is at 95%. No excuses. You're sending claims out, they're getting adjudicated appropriately, and you're getting that cash back. How are we measuring our customer service in this area where customers are concerned and worried? Are we adding to that worry, or are we allaying their fears? Are we being value added from a revenue cycle standpoint? Are we sure that we're capturing all of our revenue capture throughout the process? Are we understanding that with the providers changing their logic and their ability to pay certain things, do we know that we've got the ability to document all of the services that our providers are doing? Are they doing a good job? Are they knowledgeable about the changing marketplace? And are we taking advantage of all of these things? Is someone looking at your payer guidelines? If you look at all of these components, these are all starting really at the foundational element of revenue capture, Chargemaster, and pricing. So when we start talking about making it so that your facility is ready to thrive, this is where the rubber hits the road. Okay? And one of the things that, Lori, when we look at those concepts, I often get feedback on, how do we implement a Chargemaster process? And you talked a little bit about this a second ago, but this is really where a formal documented process for Chargemaster control. So like if I'm trying to add telemedicine codes to my Chargemaster, making sure that it goes through an organized step and process throughout my organization to make sure that everyone's involved. This is really a good chance for everybody to implement a really formal Chargemaster process, don't you think?
Absolutely, and making sure that you get it right from the beginning, because once you have things set up in your Chargemaster, it almost becomes invisible. People choose it based on the words they see or the order they're accepting, and they don't really think about what's behind it. So if it's in wrong initially, it will be very difficult to find that and fix it moving forward. So be taking a look, thinking about the resources that are available to you to make sure you get it right. On the professional side, for instance, you can be looking at your physician fee schedule and RUV schedule. From the RUV, you can find, is your bilateral modifier appropriate? And if so, make sure you set those code sets up as well. If not, don't set up bilateral codes, for instance. On the hospital side, be looking at the Addendum B file. That will give you an understanding of how Medicare expects each code to be priced, whether or not it's even active still in the current year. One thing you don't want to pull from the Addendum B file is the description, because it tends to repeat itself for multiple codes within the same categories. So if you choose their description, you will have the same description for multiple codes, and you don't want to do that. But these are some good resources that are available to you to make sure that when you set your Chargemaster up, you get it right the first time.
Yeah, no, that's absolutely right. And I think, hospitals that commit to trying to do this, all of a sudden your statements are more accurate. They're more reliable. Patients are able to discern them better. We have a better ability now to have consistent customer service going across. It is never a bad thing to have just a supreme attention to detail. When we go through, our patients really experience this. I mean, they feel it. It's something that when they start feeling and that you have control over your revenue cycle, it's palpable. I mean, when we go to hospitals, you can tell just by talking to patients if they're, the relationship that the hospital has with the community a lot of times goes well beyond the clinical side. It's really how we represent the business side. So this is just a wonderful opportunity for everyone just to change their thinking on things. And then part of that is, it's not an accident. You really have to allow your people to focus in on education and understand. So all of the pieces that Lori just mentioned, if you're not going through and finding resources to understand what any of this means, it's really hard for your Chargemaster to be fully representative and be practiced. So part of this ends up being, and this is where we can take a great opportunity here, that as we're having our revenue cycle steering committees get together to try daily to manage our revenue cycles, this is where empathy starts coming across throughout the revenue cycle. People are starting to understand what each other does. And as that happens, this is where you start identifying gaps of knowledge. Or you find out people who really have it nailed and are superstars, finding out where they go to get these things. We need to make sure that we understand what our people need to know. And a lot of this really starts becoming evident as when we get everybody in the room and we start talking about these issues, the gaps start showing up. And then we as a team have to figure out, all right, so how do I plug this gap? How do I go through and find the best pieces of education and knowledge that can make it so that my team can operate efficiently? We really need to look and say, do we take advantage of local, groups? Like you guys are on this webinar today. It's a perfect example. I mean, you're taking advantage of new ideas and thought processes that are being provided to you through the center. Beautiful, right? So we need to also do that for all aspects of our revenue cycle. Coders, are they getting access to what they need? Our billers, our follow-up people, our financial counselors, how are we doing that? Are we taking advantage of all of the free resources that are out there? Ultimately, when we're doing, when we focus in on our educational aspects, we've got to make sure that people understand, especially now, there's informational overload. I mean, I can't tell you the number of hospitals that are getting back to us and say, look, I'm getting so many emails, I can't tell if this one supersedes this one and this one, refers to a part of that one. I'm worried that I'm missing it and that I'm going to do things incorrect, right? So we really need to understand, how do we vet those things? We got to create a systematic delivery apparatus within the hospital to ensure that the right people get the right access at the right time to the right information. We understand that it's not enough to report the news or data. They just need to understand what's the solution. Focus on the reason or the need for the education or training. And this is all starting to come up, and a lot of this may be new conversations that you're having. When we're trying to fix denials, what are we really trying to resolve? The denial or the reason why it occurred, right? Once we do this and we identify it, this is where you set the expectation that this isn't a one-time thing, guys. Business office or coding or wherever, we've got to make sure that you're always going and trying to gain those levels of expertise in education. Now, Lori, one of the questions that I get a lot of right now is that, people are trying to figure out, and especially from a Chargemaster standpoint, where do I go? What resources might I have available to me to be able to understand and create a really quality controlled process when it comes to our Chargemaster or our foundational revenue cycle components. What do you think about that?
So it's true because a lot of the information in the Chargemaster is more or less standardized. You need to have certain pieces of information and you need to make sure they match. So you need a revenue code, but you need to make sure that revenue code is appropriate for not only for the CPT code or the HCPC that you might be attaching it to, but for the location or the person performing that service. So you need to make sure those things are appropriate. In order to do that, you'd want to go to the revenue code file, which is available on CMS. It will explain each revenue code, for instance, and tell you what services would be included or should be considered. Like I said before, the Addendum B file will tell you whether or not codes are active and how Medicare tends to price them. You should also be looking at maybe some of your payer websites. What code do they want? If a HCPC and a CPT are available for the same service, which one does your payer want? Do they want the HCPC or do they want the CPT? You'd have to go to the payer websites to see that. And that should be part of your process every time a new code is set up. Be comparing it to the revenue code. What's the most appropriate rev code for it? Is it the professional component or the facility component? And make sure you're looking at the right categories. What payers might want something different, and how do I set that up correctly? You'd get that information from the payer websites. Medicare frequently wants different information from AMA, so you want to make sure you have the Medicare code set up primary, because that will be the most distinctive, and then the CPT would go behind that, and then payer-specific behind that. So you need to be able to check all of these sites to understand those things. And using these, if I could just for a second here, the new codes for the COVID labs, for instance, AMA wants a CPT, and so they want this new code 87635. However, Medicare wants to know which lab performed the test. So they want it broken down further by HCPC. If it's a CDC test, they want U0001. If it's a non-CDC test, they want U0002. So in this circumstance, you would set the HCPC as your primary, and for each of these codes, the CPT would be set up as the alternate code 87635. In terms of the description, I like to use the AMA medium description because it usually tells you everything you need in, without taking too many characters. It will usually fit specifically into most CDMs and the number of characters they allow. And for this circumstance, since HCPCs both point to the same CPT code, I just insert CDC into one and non-CDC into the other.
No, and I think that makes a lot of sense. So in a way, guys, when you're looking at your current state of affairs, this is a really good opportunity just to stress test your revenue cycle and your code and your Chargemaster selection. You know, how do we have things set up? How did people determine the prices? You know, how are we using the CPT versus the HCPC? Some hospitals, you know, have done this, and what they found is that, you know, on the telehealth codes, someone went through and they set all of the telehealth codes to be technically based rather than professionally based, and then were very concerned about the number of denials that they were receiving. You know, so when you look at it, you know, how you set it up determines a lot of times the results. So use this as an opportunity to go through and really, you know, see how things are set up in your Chargemaster in this time of crisis, because this is happening real time. This isn't something that people have had weeks to think about. This is stuff that's been, you know, really changing over the last 2 weeks. So very important to try to see how that is being handled. Likewise, as we start moving through, you know, one of the areas that we need to be sure of that we're taking control within our revenue cycle is understanding pricing transparency and understanding that how we are representing these codes to the public is now coming under scrutiny, right? And there's an awful lot of confusion, and I think there's a lot of concern that hospitals have when it comes to pricing transparency. Lori, just take a couple of seconds and give us just a little history on, what's happened and what is happening, over the last year or two here when it comes to pricing transparency.
Sure. So in 2019, Medicare required that hospitals publish their Chargemaster. They called it their Chargemaster or some other form of pricing mechanism on the website so that patients or anyone else can easily see how hospitals price their services. And they wanted to make sure that it's in a machine-readable file so that others, usually competitors, can pull it from your website and compare it to their services and try to be more competitive. We're also seeing insurance companies pull these and take a look at it to see how they're priced according to, compared to how they're paying you. The 2019 change required DRGs as well, although lots of hospitals are struggling with that DRG component and haven't really successfully put their DRGs out there. It was required in 2019, so you want to make sure you comply with that as well. It requires that it be updated annually at least on your website. Now, in 2020, they came up with a lot more guidance, but they decided to push that to 2021. So effective 2021, January 1, we have to be prepared to publish reimbursement rates for all commercial payers at these same levels. And what they've decided is there'll be 300 services for which you'll have to publish your reimbursement rates. They have chosen 70 services, and the 70 services that CMS has chosen are things like your office visits, diagnostic testing, behavioral health services. The 230 that they've left for the hospitals to choose, their expectations are that these be more things like surgical services. And when you put those out there, they not only want it by payer, but they want a breakdown. So they want to know of that price, how much is associated with the procedure itself, how much with recovery, how much with drugs, how much with supplies, and then the sum of all that together by payer. So this is going to be a pretty significant undertaking for hospitals to figure out how to get this information onto their websites. Lots of organizations are pushing back on that, but so far CMS is still planning to move forward with this January 2021.
No, and then that makes a lot of sense. So let's think about the reasons why they're trying to do that. So they are indicating that hospitals are encouraged to undertake these efforts to engage in consumer-friendly communication to help patients understand their potential financial liability. And as all of us know, if we want to make sure that patients understand their financial liability, give them the Chargemaster, right? Because it is so easy to understand, right? So throughout our entire organization, half the people don't really have the ability to understand everything that's in the Chargemaster, right? We want to make sure that patients have the ability to compare charges for similar services across hospitals, right? So this really does present both an opportunity and a challenge to develop compliant and cost-effective processes that add value for our patients and promote fair and accurate comparisons, right? And I don't think anybody has a problem with that. We want to make sure that we, in our internal processes, have a defensible and patient-centric process for developing our prices. And if we do that consistently, we should feel good about what we put out to the public to be able to do. So, but the thing is that we need, as a hospital, we need to be prepared to assist patients through this change and really mitigate any damage to our revenue or our reputation because, like I said, the Chargemaster is not something that is easy to understand or is going to provide maybe what people are looking for, right? And in order for patients they got to understand the service to understand the price, right? So a lot of times they know that they're going to have a service, but it's very difficult for them to go onto your website and then be able to find exactly what they're going to receive. They understand the words, but maybe not the codes, right? So part of the thing is as well is that we've got to make sure, and this gets back to what Lori was talking a little bit ago, when we're looking at our descriptions, we need to make sure that the descriptions make sense to an average non-medical person. So here's an example of a couple of descriptions that we pulled from a recent client. And literally these were right off of the website. So we've got our level 3, 4, 2, VI, right? And we, and those are for our emergency room. But in the hospital, what they did is they didn't include the CPT in their public file. So literally the patients were just seeing level 3, 4, 2, 5, and 1. Likewise, they were seeing words like KUB and IDP. While that may mean something to you and I, to a patient looking in or a Medicare beneficiary trying to figure things out, very confusing. Likewise, we had 4 codes at the bottom, and there was confusion in the revenue cycle. They were intending to set these up as procedural charge codes, one for the procedure and then a corresponding one for the anesthesia. They ended up making all 4 of those the anesthesia charges for professional, and if you look at what the rates were, every time they do it, the volume and the revenue was doing very well for the Department of Anesthesia when they were using these codes. But again, think of the patient looking at these and trying to make a determination. They're looking at this as the procedural aspect, and really, from a Chargemaster standpoint, it ended up being the anesthesia side of things. So things matter, okay? So we have to understand, the Chargemaster is really confusing, okay? And the direct interpretation of charge descriptions, right, and pricing, it's misleading since many payers bundle charges and reimburse contractual allowed amounts rather than retail prices. Sort of, what Lori was talking about with the delineation of trying to start bundle all of these pieces so that patients can understand. Theoretically, this is exactly in your quoting process out of the OR, this is what you're trying to do. And we need to educate them. So depending on the facility, patients are going to be responsible, for the copay, deductible, or coinsurance. And, a lot of times they're going to be, that's based on the allowed amounts for commercial payers, but if I'm a critical access, now we're starting to bring in the value of the charge. We need to educate our patients. They're not going to get that from a pure look at your downloadable file that's sitting on your website, okay? Clearly, there's a gap there. So the best practice hospitals are finding ways to interrupt that gap and provide information. A lot of times, some of the pricing we put this in, some of the hospitals put this in well over a year ago. The prices have entirely changed. So now I've got a public file that is not representative of the services that we perform today. Likewise, and I agree with Lori, the DRG component has been out there, and rarely do we see a facility that has DRGs published. Now, Lori, can you just go through, because I think you found some interesting stuff when you were looking around and trying to help some hospitals on their DRG publishing.
Sure. This particular file I pulled right from Medicare, and I just took random hospitals just to give you an idea of the type of information that's out there. But for 2019, for instance, you would take the DRG and you would, because there is no such thing as a published rate, there's no Chargemaster for DRG, you would use maybe your average covered charges. And I pulled this from CMS just to show you the kind of information that's out there. Now, moving forward into 2021, when we have to put reimbursement or expected reimbursement out there, Medicare shows average Medicare payments. You would, for instance, for your payers, you'd have to do the same information. You have the DRGs in your file. Even if you're a critical access hospital, you're not getting paid by DRG for Medicare, but you are capturing DRGs. So this is probably the type of information that you'd have to put out there, and they're going to expect this for all payers. So this year, you would take the sum of all of them for your average covered charges, and next year it would be more payer-specific, both average covered charges and average payment by payer.
Yeah, so when we think about things, if patients and even internal hospital people have confusion over the Chargemaster, imagine the conversations you'll have when you start getting into DRGs. So when we start looking at things and we start moving forward, supplies become a challenge, right? So one of the things that, patients generally complain most about things that they can have an understanding of. So patients know and have an appreciation for what some types of supplies cost. They've got an appreciation for how much an acetaminophen tablet might cost. Really hard for them to have an appreciation for what CPR should cost, right? So they complain because they've got an evaluation method so that they can say, well, why am I being charged $500 for an ankle brace that I can go to CVS for $14.95, right? So we need to make sure that you've got really good policies and procedures surrounding how things are priced. When we look at it from a supply standpoint, often we will see other prices other than each in the Chargemaster, case, pack, roll. We want to make sure that all of that is at the each, so that you're not putting out information that is confusing to our patients, okay? And likewise, this is something that they can use, and that is something that they may make a decision not to come to your facility because they look at it and say, my good God, they're just so expensive. And there's really no reason for that, okay? So we also want to make sure that people understand that we've got some systems out there that have one Chargemaster that they share across all boundaries. And I may have a large hospital, some community hospitals, and critical access hospitals. Understanding that the pricing mechanisms may not work equally for all of those components, right? So we want to make sure that, especially if I've got a large PPS hospital, that Medicare coinsurance for the CA is going to be based on those charges. So really, when we look at things, how does the pricing affect patient perception, and then how does it affect patient reality? And Lori, one of the things I think that we saw recently was a letter from a commercial payer surrounding their issues with paying secondary charges on critical access patients. I think that's correct, right?
Right. That particular letter was because the secondary insurances tend to pay the balance after Medicare if it's a covered service. That particular payer was saying from a critical access hospital, they would no longer pay the balance after Medicare. They would only pay the 20% coinsurance, and they would leave the rest of that to the patient balance. So the hospital would end up balance billing the patient even if they had secondary insurance. And that is going to be, if more and more insurance companies pick up that kind of behavior, that's going to be problematic for insurance companies, for hospitals when patients have purchased secondary insurance and find out they still have significant balances after.
No, it's exactly right. And it kind of goes into, when patients are looking at it and trying to understand their obligations, where are the hidden add-on costs when it comes to things? A lot of times we'll go through and we will quote certain things, and all of a sudden recovery time or technical anesthesia, stuff like that we may take for granted or not really understand that's part of the total bill. All of a sudden these things show up and the patient is getting something different than what it was quoted. So patients are looking at it and trying to understand, what is my cost? And really, how does this compare to other facilities, even though I really don't have a mechanism to be able to equally compare? And one of the things that I think as we started looking at things, and Laura, I'd like you to go through this, because there's really, two different languages that are being spoken, whether it's a PPS reimbursement model versus the CA. So Laura, can you talk a little bit about your findings with this?
Sure. When we talked a little bit before about the types of references we should be looking at and how we educate ourselves, I like to go out and read the MedPAC reports every year because it gives me an idea of where the the different entities expect that we go in terms of how we handle different things, how we set up our charges, how we bill our customers, how we track services. And in this particular MedPAC report back in 2016, it was acknowledging how much more patients pay for services in critical access hospitals because of the way the cost structure is. Critical access hospitals are reimbursed on a percentage of a cost-to-charge ratio. However, the patients pay the coinsurance based on the charges. So there might be a significant discrepancy between those two that ends up having the patients bear significant burdens, depending on what kind of markup you have in your Chargemaster. That MedPAC report, I want to point out, it was important to note, did say that there should be a policy change for beneficiary coinsurance. That report was asking CMS to look at a different way to charge patients for balances after payment. However, that was 4 years ago, and they still haven't done that. They did signal back in 2019 that that they were working on it, but it never went anywhere. So until it does, this disparity will grow. We'll continue to see patients paying much, much more in some settings than in others for what the patients perceive to be the same exact service.
And I think one of the things that we had just last year, there were a couple of PPS hospitals that were trying to take a look at the difference in out-of-pocket from a PPS to a critical access, and this was just going through, and this is one of the things that they tried to do, is they just took the charge of the service that they got off of a critical access hospital website, and they just said, if I assume a 50% cost to charge, what would the 20% potential coinsurance be to that critical access patient versus what would the PPS component be for services that we might like to grow market share. And they were specifically looking at both CT and MRI, and you can see, just like Lori said, there's a huge discrepancy between things, and all of a sudden when we start talking with Medicare beneficiaries, this is real money. Likewise, they were looking at what it would cost to do things out of the emergency room, and it was the same type of thing. They're not assuming any bundling or anything, but just straight line cost. There's a huge difference between potential patients' balances from not assuming secondaries and stuff, but you can just see. So this actually really impacts people. And what we have seen is over the last 18 months or so is larger PPS hospitals trying to figure out how they use that as a competitive advantage. And that's definitely something that's happening. Lauren, just to finalize the MedPAC piece, can you just ram through real quick on some of the findings that kind of accentuate what we just said here?
Mm-hmm. The MedPAC report basically said exactly what John just said. They looked at diagnostic services, CAT scans and MRs, and they were seeing that the price markups were significant in those particular services. They acknowledged in that report that Western states didn't have quite as high a markup as we tended to see in the Northeast and the South, but it was still significantly higher than in other services. Interestingly enough, it also showed that those services are out-migrating out of critical access hospitals. So critical access hospitals are actually doing fewer and fewer CTs in particular, and MRs as well, because the price discrepancies are so high. So they're noting that not only are they seeing this big markup issue, but they're also seeing a sharp decline in visits. The other thing that they noted that people really need to take a look at, hospitals should look at for their Chargemasters and how they track over to their cost report, that MRs and CTs were frequently hidden in the diagnostic radiology portion of the cost report. And they really should be carved out and put in their own areas so they can be evaluated appropriately.
No, absolutely. So when we pull all of this stuff together, what's the reality? So we recently did some work with 10 different critical access hospitals, and when we pulled the information together and compared their current prices compared to what Medicare would reimburse from an APC standpoint, 6 of them, had prices that were set at 0. Okay, 52% of the departments noted within those 10 CAs had prices set lower than Medicare. Okay, when we add everybody together, 79% of the departments were noted with prices lower than 2 times Medicare. So these are for critical access hospitals. So if you look at it, and I would ask each of the CFOs and CEOs, do you think if this was in your emergency room, is the cost of providing the service less than what Medicare would reimburse? Obviously, the answer is no. Conversely as well, 74% of the departments noted prices set higher than 5 times Medicare. So what you've got is this huge variability, okay? So in total, for all of the lines that were payable in their Chargemasters, almost 9% of the codes were set lower than Medicare. Almost 20% were set lower than 2 times. So this is where a lot of times we get critical access hospitals who are trying to be conservative, but the problem is that their prices aren't in any shape or form relational to their cost of providing the service, in a lot of times, we've got hospitals that are pricing things because of a mistake at 47 cents when it's supposed to be $47. They're getting 50% of that 47 cents. It's a mistake. This is why you have to be using this time to be to go after and make sure that everything is correct within your Chargemaster. So we already understand that Medicare is advertising the benefits of having elective procedures outside of your hospital. Okay. The question is that they said that about PPS. Are they going to do the same thing for COS? Okay. If that's true, regardless, how am I going to measure up? How are we going to be able to handle the patient calls when they come through that say, hey, look, I think it's cheaper and better for me to go here versus your hospital? Are we even prepared to be able to have that conversation? Now, this was a very interesting piece that Lori provided to me recently when she got this off of, I think, Lori, you got this off of Medicare.gov, correct?
Right. We're always used to going to CMS. It's actually Medicare.gov, yes. So we're used to going to CMS to get our information. That's the hospital and professional side. That's where we get all our information. But patients go to Medicare.gov. They don't go to CMS. And when you go to the Medicare.gov site, what you see is the information that's being provided to patients. The guidance that Medicare is giving them is, hey, if you go to somewhere else, you can get this service cheaper and it will cost you less. So they're actually publishing out there for all kinds of common procedures what the patient would pay if they would have the service in an ASC and what the patient would pay if they would have it in a PPS outpatient department. And my expectation is we'll start to see this same information have a third column for critical access hospitals on some sort of an average. And likewise, I expect this to expand into those high-value radiology services as well and include what they expect to pay in a freestanding surgery center versus what they expect to pay in a PPS setting. And in a critical access hospital. So as we move into this new world of patients being encouraged to price shop, we're going to have to learn how to compete against more and more of this and set up our pricing in such a way that we can explain to the patient and we can generate the conversation around what we want it to look like.
And actually, I think we came across recently a denial that a critical access hospital had received from a commercial payer because they were not going to allow, from a pre-op standpoint, they would not pay for a MRI to be done in their facility. They were actually requiring it to be done in a freestanding site. I'm correct on that, right?
It was actually the authorization that was denied. The hospital received a letter saying that that particular payer would no longer pay, would no longer authorize high-value radiology services in hospital outpatient departments. They would only authorize them in freestanding centers. And in that particular hospital was confused because they were 75 miles from the nearest freestanding radiology service, and yet they were still getting that letter from their payers.
No, a lot of confusion that's going on. So, as we start moving forward, we've provided a whole series of slides for you to act as resources. But, so next steps, so we want to make sure that when you're looking at your Chargemaster and you're reviewing things, do we have a variable process or do we have consistency in pricing? Are we looking at it from a perspective of code descriptions? Do we have deleted codes, all right? Do we have a comparative in place to make sure that we can tell whether we are priced appropriately? How would we even tell? Do we even have a policy or procedure? Do we have a mechanism for patients to engage with us other than their clinical people? So often, the people who are getting your pricing questions and questions regarding charges are the people who are providing the service. And often they're not the ones that are armed best to handle that. How do we handle that? Do we have somebody that we've trained? Do we have financial counselors who are usually wonderful at this? We just have to train them and get them so that they can understand the concepts so that they can use their empathy to help patients understand their obligations and their requirements, right? So ultimately, regardless, there's still time to get it right. I mean, one of the things that CMS has basically said is, it's really hard for us to come up with penalties because we don't really have a baseline for being able to figure out if you're in compliance or not in compliance, right? So they have started to expand that. There are things that we have to be concerned about in 2020. You know, the proposes evaluating complaints made by individuals, i.e. your patients or other entities, to CMS, right? They've proposed things such as a $300 per day penalty in 2020. You know, I haven't heard anybody that's had any type of penalty actually levied thus far, but we just have to make sure that eventually they're going to figure this out. Really smart people over there. They are going to try to work this. We just have to be prepared. So let's just use some of this grade area to make sure that we have the opportunity to get it done. So what are our next steps? You know, really take this time now to review and clean up your Chargemaster. Implement a patient-centric and defensible pricing methodology. Look at everything through the patient's eyes. We want to make sure that you update your Chargemaster to be reflective of the current service provision. Don't have it be one that's outdated, okay? We want to make sure that if we do have financial counselors, we have a process for educating them. We have a process for making sure that they understand the different questions that might come through. A lot of times we'll help script some of these responses, but you have in your process that regardless of the question, people are being sent to the same resource that you trust within your facility. Very important, consistency, and this is where quality starts coming in. Part of the quality operation is handling these same questions the same way each time, okay? So one of the things that we've got throughout the rest of this, your slide deck is, you know, suggestions on how to communicate some of these things to your patients through your website, maybe some language that you can put in to direct people to financial counselors, or just understand that itemized charges may not reflect the payer or patient responsibility. Put some disclaimers on your website. Be intentional about this. Use the intention to drive patients to the best resource. Don't allow them to figure this out on their own. Put some FAQs up there. You know, you're going to have the same questions over and over again. Use your website to control the dialogue, to control the answer, to control the consistency of the answer, so that as patients talk to somebody and go to your website, they get the same answers. Wouldn't that be nice, right? Same thing. Be very intentional about those steps, you know? So as we start going through things here, you know, like we said, administration has to make the revenue cycle, and more specifically, the Chargemaster, a priority. The revenue cycle culture must be seen through the patient eyes and focus upon expectation, quality, and education. If your facility is going to thrive in this period of chaos and the revenue cycle is going to perform exceptionally, there's no way that you can do that without having expectation, quality, and education as a core concept. The entire revenue cycle should take every opportunity to scrutinize and review the CDM. Every time something comes up, you should make sure that we are doing no harm, that we are representing things to the best of our ability. We want to ensure that the facility employs a patient-centric. Now, this is important. We mentioned this throughout the process, but understand what the patients are looking at and their expectations, that we can defend it to them, and that we feel good about our pricing. The pricing and our revenue cycle should not be something that no one wants to talk about. It should be something that we're proud of, okay? So it's not going to happen by accident, though, okay? We have to understand and look and see that our Chargemaster has good descriptions, that, you know, if we're going to start talking about DRGs, do we even understand them? And how are we going to explain them to our patients if they start having questions? You know, do we have those financial counselors or superstars within your new revenue cycle who have a wonderful way of empathizing with patients? Important for them to be identified and put those people in the place to succeed and really be your ambassadors of your revenue cycle. You know, we've got to make sure that we're prepared for the annual updates. Like we keep saying, success is not an accident. In daily informed action is absolutely the key. And as we start wrapping up here, and I'm so appreciative of your time with us, we did have a couple of quick questions that came through, and I just want to make sure that we address them. So thank you for submitting these. So one of them that Lori just came through and said, we've had a great deal of difficulty implementing a pricing policy within our facility. Do you have any suggestions on where to start and what the policy should include? 30 seconds, please.
Sure. Couple things. You want to make sure that you have a pricing policy specific to supplies, how you're pricing your supplies, how you're pricing your drugs. If you have send-out labs, you should carve those out and have a separate policy for those as well. And then your policy should say how often you review and make sure you're still in line. Because if you do standard markups every year, you want to make sure the same CPTs don't come out of variability because they were put in the Chargemaster at different times. So review it every year and make sure same CPT, same price.
No, great stuff. Another question is that you mentioned a commercial payer denied a hospital or a pre-authorization because they wanted the service to be formed in a freestanding site. Can we expect more of that? And do you have a suggestion if we're a rural hospital, how we might combat that denial and pre-auth?
I expect to see much more of that. I would be surprised if we don't see that happening more and more, especially once we have to put commercial rates out on the Chargemaster. The way to combat it, some of it you will not be able to successfully combat, but have structured appeals. How far are you from the next site? Why was it important that they have it here? Maybe the patient had allergies and needed to be closer to a medical center just in case. Have some structure around how you plan to appeal these because you're going to get these denials.
And then last question, and I thought was a pretty good one here. So our facility is currently experiencing lower volume. Are there actions or steps that you suggest we take within the Chargemaster during this slowdown to prepare for our hopeful return to normalcy, which I think is something that we're all hoping happens very soon?
Mm-hmm. Yeah, lots of hospitals right now have sent their employees to work at home, and people have a completely different structure to their day. Sometimes some hospitals have volume that's way down because they've closed their surgery centers, they've eliminated elective services, and other ones, unfortunately, are very, very busy right now. If you have particularly billers and staff in those areas that have downtime, if they're working at home, you can still give them an electronic file of your Chargemaster. You can have one person be comparing CPT to revenue codes. Are they making sense compared the way they are? And you can give them a list and a structure. You can have somebody else comparing price to CPT. Carve out Pro versus Tech, keep those separately. And if I have a facility CPT, is the price the same throughout? And these can be done through sorting, through simple formulas. You can carve out different things and give them to different people. Give them and say, does the description make sense? If it doesn't make sense to them, it won't make sense to your patients.
Yeah. No, that makes all the sense. So as we wrap up here today, realizing that there's a lot of information here, you should absolutely feel free through our contact to reach out to us. We're happy to answer any of the questions that you might have in addition to the ones that were submitted. Specifically, we're getting a lot of questions in regards to, for instance, one of the slides that you saw around the COVID-19 lab testing. We've actually created a coding support at stroudwater.com email that if you have questions around any of the setup of those codes, feel free to reach out. We're more than happy to help to make sure that you have the best platform to thrive in this chaotic environment. As we wrap up here, again, thank you so much for spending a little bit of your time here today with us. We do hope that this gives you the opportunity to look at your revenue cycle maybe a little bit differently, but also take the advantage of it to maybe take control of some aspects of your revenue cycle, especially when we're all feeling that we're a little bit out of control nowadays. But take intentional action, do it every day, involve your people, communicate, and by all means, we hope that everybody stays safe and is better on the backside once we do start getting back to normal and rebounding. So at that,